Good morning, everybody. Welcome to the 2024 Health Literacy Summit. My name is Anita Arno. I am the Chief Health Equity Officer for DC Health. And this has really been a labor of love for myself, my team, and several of our colleagues at DC Health. But without further ado, I would like to introduce Dr. Ayanna Bennett, Director of DC Health.
Well, good morning, everybody. Good morning. We have been treated well this morning, so I see happy faces. The chocolate muffins are good if you miss them. I'm really pleased to be here. I'm pleased that this process, which has, I think, been a really important step for the department, and I think a worthwhile thing in the community, to really come to a place of not culmination, because it's ongoing, but a place where all of you can take a moment to appreciate what's been done and what you're going to take forward with you. The health literacy project, the collaborative itself, is the significant work of all of you, and I want to be sure we thank from the department side, Leah Varga and Anita Arno, for being the face and the front of that, and I hope that they have represented the department well, because I see a lot of people who've been engaged in this process, so I think that means we have been good partners, which I hope is how we will always go forward with you. I love events like this where we get everybody in the room together, because we know that we are all equal partners, even if we cannot make all the funding decisions. We don't either, the feds do. But we know that even though we're all subject to constraints, we all share a duty of care to the public. And we are responsible for helping you meet that by helping you with this concept of health literacy and that you are passing on to the public. I am very appreciative of the way in which we have made health literacy so much a part of what you're doing and what we talk about in public, that we are recognizing it as a social determinant, that the power to bring health to the community is actually in the hands of the community, and that we are stewards of the supports they need to do that. So thank you very much for being here, and I appreciate everything that you all have done, and I'm excited to see some of what you've come up with. Thank you very much, Dr. Arno.
Thank you so much, Dr. Bennett, for not only joining us, it's nearly a year now, but appreciating how important community engagement has been for the work. And this was basically a process that was built on that, or has been built on that. So with that, I'm going to, first of all, just give you a quick overview. You've all seen you have a program in hand. So very quickly, I'm going to just say what we're going to do. We have a full program from now until 4:30 this afternoon. We're going to have, after I give an introduction to the whole process, because it took some planning before we even started, we're going to have a plenary session that goes through lunchtime. We'll have a 15-minute break at about 10:45. After that, our closing session for the morning will be our panel discussion and then some Q&A. Then we'll have lunch in the ballroom, which I think most of you have already been, where you've had breakfast. And then in the afternoon, we'll have several concurrent sessions when you get to hear directly from each of our partners and the work that they do. And then we'll close out the afternoon. You'll see kind of a summary of what that looks like at about 4 o'clock, and we'll say, thank you for being here at about 4:30. But this is just a culmination at this point, but not the end of the work. So that's what we're all looking forward to. So thank you, Dr. Bennett, and thank you all for being here. So I think we can proceed with the slides. I think this is the clicker. I haven't tried it yet, so let me see how it's going to work, right? Oh, there we go. Sorry, that should have been up earlier. I apologize. Here I am, and that's me. So now we're going to do this overview. And so what is advancing health literacy all about, right? So first I'm going to give you a little context, because we actually started this process I would say in the middle of the pandemic was when I was writing the grant. And we really started with this idea of doing some research to see how could we better interpret what was happening on the ground. This was even before, long before vaccines, long before almost anything. We did, this to me was, I call it our quick and dirty map, and it was a little bit, it is data informed, but what we put together there was just what the data was kind of suggesting early in the pandemic as to what the drivers were. So this is what we started with, and you can see, I'm sure most of you have seen this map already, but here it is. But really, we were in the even before the pandemic, we had discussed the need for health literacy in the district, largely because we knew we had high rates of health insurance, but we were still seeing the same kinds of things happening. Folks were still using the emergency room, but ultimately, folks were not getting any better. So, you know, these insights from the map to the right were really what started the way this project was framed. And then we saw the waves. So the guesstimates, as I called it, were good. They were guesstimates based on data. We had one wave and we had a second wave. But do you see how it correlates? And these were the waves that we had. And then, of course, we planned the process based on that with the idea that we already knew in August 2020, Healthy People 2030 came out with new definitions for health literacy. We all knew that the old version left much to be desired. And so we incorporated that idea that what we needed to do, especially given the outcomes of the pandemic, that we needed a much more granular approach at the neighborhood level to understand what was actually driving a lot of the differential outcomes. And I say this, I've said it in public before, I say this to my colleagues at DC Health. We like to say sometimes that we did a good job during the pandemic, and I'm sure it was good-ish. But I do think if we still had the same kinds of outcomes that we could have predicted, then we certainly did not do a good enough job. So that's really where the work starts, right? So what we did was, given based on the data, that we needed to focus in a more granular level at the sub-ward level. So even though you'll see we state wards here, we actually had an intent to use the kind of analysis that I showed you on the first map to really drill down and to learn, not to go and tell, but to learn from community what would have worked better, how could we have worked better, and how could we change our practice. So this is a practice change project, and it's definitely community and nonprofit driven. So what does this look like? Just so everybody's on the same page, what is health literacy? These are the two new definitions. We have personal health literacy, which is a modification of the old definition that we had before, and now we have organizational health literacy. What that means is that we can't, and we knew this before, we can't just assume that people will know stuff if the organizations that support them, whether it's in healthcare or elsewhere, does not do the right work and arrange themselves in a way that is supportive of our individual and collective learning. So it's also a two-way conversation that we need to think about. So this is why it's important. You'll see it improves health equity. I won't get into the detail. We're going to share all of these slides, but you know, the broad landscape of what we've talked about is for us to get better outcomes. And you'll note here that, and this is a set of slides, most of the data that's out there, even when we talk about organizational health literacy, is really talking about health care organizations. What we observed in the district was that we needed a better model to bridge folks in neighborhoods to healthcare organizations. So that's where we started our work. And then we thought about what can a public health organization do? So that's our role. How can we do that? We think of ourselves as a chief health strategist, but we also have to approach this with a whole lot of humility because we cannot do it alone. We need to work with the community. We need to engage the lived experience of residents, recognize the barriers to access and barriers to benefiting from healthcare. We need to co-create solutions, build a strategy around these insights, and implement organizational health literacy for us, for you, for most and every organization in the city, healthcare or otherwise. So that's what the learning has been about. Our project innovations are about leveraging non-health CBOs, right? So we did not go out and find out who is good at health. because the people who are good at health were always here. What we need to do is figure out who is really engaged at the community level and know their constituents and know how to reach them. We need to highlight professional health literacy, which is kind of rolled into the healthcare organizations, but we never do get to really talk to them directly as we ought. And then engaging our unique audiences. And then finally, what we've been able to do in our no-cost extension years support some additional FQHC practice transformation. So here we are. I'm going to click through this. We are really centering people. So really our focus is on how do we support personal health literacy. And yes, we understand we're all living through a context of social and structural determinants of health, including the organizations that surround us, and so do the professionals. But our focus needs to be on how do we get both the professionals and the organizations to support people in the neighborhoods. So finally, these are the 3 definitions. I'm just clicking them through, but what I want to say is that as part of the collaborative, we've actually developed a professional health literacy definition, because one did not exist in the language that we have. All right, so this is also a framework for how we think about health literacy in the district and what this program is about. These are our 3 audiences: individuals, organizations, and professionals. These are our primary customers. If we don't do it right, these are the folks. How do we support professional health literacy? We have organizations, and these are the critical conversations that need to be had between individuals and professionals and individuals and organizations. And it needs to be individual and community friendly and purposeful. And so we've, as I said before, we've focused on non-health CBOs and non-health professionals in this phase of work for this project. We know the other parts still exist, but there's a lot of money and resources in the other parts of this work to fund that, and we are planning to engage them along the way. So, what is our project about? And we really about building a population health literacy model, essentially. We really want to ensure that we have, and you've all seen this, the Health Literacy Collaborative. We've had the 2 other pieces of the program, which are community-based organizations and collaboration, practice change. But we leveraged the work that many of you started with the COVID-19 health disparities work. So that's how you kind of got your street legs about what public health work could look like. And then we started doing this work in terms of health literacy beyond that. So here we are. I want to say these are our 3 buckets. These are our partners. For the folks who have not seen us before, 6 small CBOs started with us. Then we added HEAL DC and La Clinica, which was our first health serving organization. And we also have these additional partners internal to DC Head, District Government, Howard University, and Bain. So this is our timeline. And quickly, here's a map of where our organizations came from and what the work looked like. So ultimately, what we've tried to do, and these are the ingredients for success. I'm just summarizing, and you're going to hear a lot about all of them for the rest of the day. Collaborative learning, audience-informed message development and feedback, intentional outreach, social needs assessment, tool integration, learning and practice change portal development, project measures, quantitative and qualitative, collaborative program evaluation, learning distillation, engaging sustainably by starting with the end in mind, and sharing results for collective knowledge building and use. And so this is our first sharing results for collective knowledge and use. So that is it. Thank you so much, and this is just sets up what you're going to hear and learn for the rest of the day. I think the first session that's going to come after me is learning about the collaborative learning model, and I invite those presenters to come to the table. They will introduce themselves, and you'll see teams from DC Health and our partners.
right, good morning, everyone. My name is Edrin Williams. I am a program manager with Leadership Council for Healthy Communities, overseeing the Advancing Health Literacy Program.
Good morning, everyone. I am Kimi Yonamine, and I am with the Office of Health Equity at DC Health.
Today, Kimmy and I will talk a little bit about the Health Literacy Collaborative. So this collaborative was really designed to be a central hub where stakeholders from various sectors can come together to share insights, resources, and best practices. And so really the goal of the Health Literacy Collaborative is to strengthen community-based partnerships that leverage established connections and enhance wide implementation of a health literacy plan. So by convening this collaborative, we aim to foster a supportive ecosystem where organizations can learn from each other, collaborate on projects, and collectively address health literacy challenges. We've also worked to increase the availability, dissemination, adaptation, and use of culturally and linguistically appropriate evidence-based health literacy practices and interventions, and engage with CBOs to develop organizational health literacy plans. So as Dr. Arnold mentioned, we transitioned a lot during COVID-19, and at the initial start of the grant period, we focused a lot on improving COVID-19 health outcomes. So as a collaborative, we discussed the importance of robust testing, efficient contact tracing, and widespread vaccination to curb the spread of COVID-19. And we really emphasize the significance of health literacy in promoting and understanding the adherence to the public health guidelines. We introduced the concept of Living Well workshops and their role in empowering individuals to manage their health conditions effectively. And we partnered with DC's Health Department, OCHR, I won't say the whole acronym, OCHR, and our CBOs in the collaborative to promote COVID-19 health literacy. So we did so, and we discussed the creation and utilization of community resources to support public health initiatives and to highlight specific initiatives and partnerships aimed at leveraging collective resources and expertise. And with the CBO engagement, we really focused on highlighting successes, challenges, and opportunities for collaboration to inspire our continued efforts. And so we shared stories from the field, updates, and really opportunity for collaboration. And also the collaborative was offered as a shared space for technical assistance and guidance from DC Health.
I'll be talking a little bit more about CBO engagement. So in order to cultivate a collaborative learning community and a community of practice, we created different spaces to partner and collaborate. So we had our monthly collaborative meetings, and that's where we shared the stories from the field. We had roundtable discussions. We troubleshoot different challenges that partners were having, as well as participate in training by subject matter experts. We had quarterly meet and greets at partner sites, and we got to really experience the organization, the staff, as well as their health literacy efforts. We collaborated in community events. So you'll see on the screen a picture of us attending a community outreach event as a collaborative. We also had monthly health messaging meetings, and that's where we received feedback from our CBOs, and we co-created more communication campaigns and communication materials, and I know my peers are going to be talking a little bit more about that later in the presentation. We also had a Slack channel where we had consistent communication. That's where we announced any urgent announcements, as well as shared any events and flyers. And last, we had our monthly one-on-ones, and that was tailored time with our CBOs, where we provided tailored technical assistance, as well as go over the implementation of their work plan. In 2020, 2023, we developed and implemented a training curriculum. So this was in collaboration with our partners and our agency staff. As you'll see on the screen, our training curriculum ranged from a level setting of health literacy to communication best practice, program evaluation, data use, and storytelling. This was led by subject matter experts in the community as well within our agency. Some of the lessons learned there was the importance of prioritizing topics and having consistent check-ins to adjust any topics, any content, increasing interactive activities. A lot of these trainings were done virtually, so we learned to set expectations with trainers and increase interactive and engagement discussions during the trainings, as well as offering live language interpretation to increase access. Overall, we learned that organization, flexibility, and openness to feedback were essential for implementation. And I'm also happy to share that the PowerPoints and recordings are available to the public, and they are posted on the Living Well portal, which my colleagues will also talk about later in this presentation.
And lastly, Kimmy and I just really wanted to highlight some sustainability strategies that we talked about as a collaborative, and this will be talked about in future sections later today. But by implementing sustainable strategies, we can ensure that continued engagement and collaboration with CBOs, ultimately leading to long-term improvements in health literacy in the district. So we want to continue to host our health literacy collaborative meetings, continue with the dissemination of the COVID health literacy curriculum to CBO staff, offering trainings on health literacy best practices, continue to share resources among CBOs and others developed by DC Health, and partner together for community events. And that's it for us. Thank you.
Thank you so much, Kimmy and Ed. And I think next we're going to have a little fireside chat. So Melinda and the rest of the team, please join us. Thank you.
Good morning, everyone. It's very wonderful to see you all here today. We're going to switch things up a little bit. So instead of a PowerPoint presentation, we are going to engage in a little bit of a let's talk about it. So again, my name is Melinda. I'm a Community Relations Specialist and Language Access Coordinator with the DC Department of Health. And with me today, I have Jackie Rumeld, who is the Program Manager for Healthy Schools, Healthy Communities from American University, and Ed Hardy, who is the Community Engagement Coordinator with the Far Southeast Family Strengthening Collaborative. Together, we will be discussing advancing health literacy through community outreach and language access. So we're going to jump right in, and I'll be asking them some questions. So our first question is, why was it important for your organization to be a part of the Advancing Health Literacy Collaborative?
I think for us, we really enjoyed being a part of the collaborative for growth and opportunity purposes. We loved learning more about how we can better serve our communities and better increase health literacy and health equity with the communities that we work with. It was also a great opportunity for us to get to know other organizations for potential partnerships, for our pop-up events. So for us, the greatest thing was the growth and opportunity that came out of it.
For Far Southeast Family Strengthening Collaborative, we really wanted to make sure that we were tackling the issues that we were seeing with our families the most. And one of those was health, right? There's a lot of issues going on with health and concern, especially in the Ward A area, that are not being tackled just because of lack of information. So this was a good opportunity for us to really be able to dive into that and figure out strategic ways to do that.
Thank you. And can you tell us a little bit about what are their strategies that you use to incorporate health literacy in your outreach activities?
Yep. So with us, we have a strong, effective community engagement presence in our community. So it really wasn't a hard shift. It was just more so about having that messaging and being able to provide that messaging and being able to get the people out to the events that actually had health-related resources and stuff of that nature. And when you do that and you kind of consistent with it, it brings the people out. They're going to keep coming.
Thank you.
For us, it was sustaining our partnerships. They really were able to bring hundreds of people to these events, and we were able to collaborate with our partners on pre-existing health fairs or other events that they were having, food drives, vaccine clinics, and through those events, we were able to have the best outreach possible.
Great. So it sounds like definitely a lot of grassroots initiatives and in really engaging with the communities, being involved with the communities and partnership building. How did you assess if these strategies were helping to increase health literacy within the communities that you were directly serving?
We would use surveys at the end of our pop-up events, at the end of the station. We would ask a number of health literacy related questions, questions that related to the doctor-patient relationship, food access questions, where people would go to find health information. And through those questions and the results, we were able to better understand the communities and their health literacy levels.
And we kind of moved in the same direction, just making sure that we found out exactly how they was responding to the messaging that we was providing, whether or not the healthcare providers in their area were actually doing the work. Just really talking with them on a straightforward level and just kind of getting their understanding.
Wonderful. So you mentioned, Ed, for you, you primarily focus on communities in Ward 8. So my question to the both of you is, if prior to this grant, did your organization have a focus on providing outreach services or just services in general to the limited English or non-English proficient communities?
For us, our primary focus is also Ward 8 and Ward 7. So when it came to the non-English speaking communities, we really found them through our partnerships. We didn't really have too much of a focus on non-English speaking organizations that had members that weren't English speaking, but the partners that we've had have always had communities of non-English speakers, and we've always made sure to have a focus on those communities by having flyers or informational pieces that were in Spanish if those communities spoke Spanish, and to have staff members who were bilingual as well.
Definitely, we just kept it simple. We didn't try to do too much out of the ordinary because the population that we deal with didn't really have those issues, but we did have messaging that was in the Spanish language, messaging in different languages. Also, on our outreach teams, I can remember when we had Elizabeth, she was bilingual, so she was out there with us in outreach. So even JoJo, like we had a few like different initiatives of the way we move, but we didn't have a big issue with it because primarily our constituents, they spoke English.
Thank you, but certainly having bilingual staff available also assisted you, because I remember you mentioning, but I remember also you mentioning that through some of the work too, you were starting to see how within Ward 7 or Ward 8, you were starting to see an increase of communities who had a limited English ability, and how that was very helpful. Yes. So hearing about that was really great, and also about the translations, and that was something that I know you and I both worked on very much. But just seeing how both of these organizations really work to meet the needs of the communities and expand their outreach to other communities as well was really great. So if you can share what were some of the best practices that your organizations developed throughout the work you did with advancing health literacy?
I think a big thing for us was we did some focus groups that got people out where you were able to kind of hear like front and center from the providers themselves, getting those people in the room and being able to have that information available to them. I think that was one of the biggest things that helped with our advanced literacy.
For us, I would say it was joining our partners on their pre-existing events and kind of collaborating with them. Instead of being the main focus and the main part of the event, we were just an addition to them. Also, I would say we were not a health fair. We were more of an interactive experience. We weren't talking at people. We were having conversations with people and having interactive activities to keep people engaged and keep it more fun, even.
Great. Were there any challenges that you experienced with trying to reach the particular demographics that you are trying to target during this experience? And if so, do you have any tips for any organizations looking to engage in this type of work, or how to potentially have some foresight in being able to anticipate some of these challenges and work around them?
Biggest challenges. I love the youth, but the youth was the biggest challenges, right? You got this message, you had this information, but sometimes they just don't want to hear it. They feel like health, I can worry about that when I'm 40 or 50 years old, right? When I'm 15, 17, 18, I'm not really thinking about it. So that was probably the biggest challenge, but I would say to any other organizations that want to reach the youth, be innovative, talk with the youth, find out exactly what the youth are looking for. Like we were going through some puberty messaging that was great. So I think that you just got to keep finding out ways to really get them to pay attention.
For us, I would say maybe the biggest challenge was the language piece. If somebody didn't speak English and if we didn't have a bilingual staff member there that day, that was a little bit of a challenge to keep people engaged. We were still able to communicate with them to a certain extent, but you still want to make them feel like they're a part of the rest of the community and being served just like the rest of the community. So I would say please have bilingual staff. It's very helpful.
So our final question is looking beyond the grant, how will organizations continue to advance health literacy and engage with diverse audiences, including our limited English and non-English proficient communities?
We'll continue to push through our community engagement, push our initiatives that we have, push our fairs, because as you know, we do a lot of great events, so we'll always make sure that we have some health components pushed out there.
I would say, again, sustaining our partnerships and staying engaged with us and engaged with them, working with them in the future. They've been a huge support to our program and really the foundation to our program. So keeping in touch with them, keeping a good relationship with them, prioritizing the partnership, I would say is most important.
Well, thank you both for your continued work in advancing health literacy in DC. Jackie and Ed here, if you want to learn a little bit more about their initiatives as well as our other CBOs, we invite you to stay for the afternoon sessions to learn a little bit more about their specific organizations, but the work that they did throughout the grant.
Thank you. So I think we're going to welcome the next team to the podium. They're going to talk about messaging and materials. Sorry, I have my mask on.
Hi, good afternoon, everyone. So my name is Monica Castañas, and I work with DC Health in the Office of Communications and Community Relations.
Good morning, everybody. I work with Latin American Youth Center, and I am our coordinator for our health literacy program.
Hi, hola, good morning, everybody. My name is Alejandra Sepulveda. I'm also at Latin American Youth Center, and I'm the health literacy community mobilizer.
And we're going to be talking about how we've worked together to co-create messaging as part of this project.
So a little overview about what we're going to go over today. We'll talk about the roles of organizations participating. We'll talk about the community feedback process. We're going to go over a snapshot of our collaboration with community-based organizations, specifically Latin American Youth Center. We'll go over some projects that we completed together, talk about advancing health literacy, community-based organization feedback, tips for creating a feedback loop, and impact and future direction.
Okay, so in regards to the roles that we all played in this piece of it, local health departments use communication to influence policymakers, engage the media, educate the public, deliver calls to action, and inspire positive behavioral change. but we can't do this work alone, right? So we started working with community-based organizations, and they play a vital role, as Dr. Arno mentioned, in reaching underserved and underrepresented communities with health information. And one thing that I really loved about this project is that you all as CBOs were not quiet. You influenced everything that we created together. So just as you were excited to work with the DC Health Department, we were excited to work with you.
So to obtain the community feedback, the process will usually start with DC Health requesting CBOs and our audiences for feedback on different health messaging materials, as well as feedback on the Living Well portal. And moving on to that, specifically at LAYC, we developed a short process to review and get feedback from our staff as well as from our audience, which is mostly youth. And this looked like mostly obtaining feedback in person, as we saw a high preference for in-person communication as well as informal discussions instead of filling out a survey digitally. And afterwards, we would implement this messaging materials, taking into consideration all of this feedback, and moving on to our last step, which is the process improvement, again, taking into consideration any further feedback after the implementation, and really with the goal of strengthening both of DC Health and LAYC's ability to meet our community's needs.
So this is just a quick little snapshot as to how we work together. So we as DC Health really wanted to get feedback from the communities that you represent. So we engaged you in getting this feedback, and then we, as Kimmy mentioned, provided space for people to kind of share their feedback, share their ideas, and a lot of the times you all inspired most of the work that we did.
Every suggestion leads to process improvement on each side. That means that every single time that we gave DC Health a suggestion for a flyer, every single time that they shared a flyer with us or a campaign message with us because they believed it would be beneficial, each one of us improved our process so that we could best deliver feedback and improve it for our community. Now that staff have a strong connection to these materials when we're implementing, then we're able to create better buy-in with staff and clients. So that means if I'm directly asking staff members at Latin American Youth Center their opinion on a campaign piece and allowing them to give me feedback in that process, when they later share that same piece with a youth, they have familiarity with it, they understand what the piece is about, and they understand the various messages that we're trying to get across. A few collaborative projects that we've completed together. We made a COVID-19 toolkit. We created informative one-pagers on various health conditions, tailored to community health needs. Oops. I'm so sorry, can you go back? We went over MPOX, we talked about that in depth. We had a really easy time receiving information around MPOX when it began. The collaborative was already in place, and we were able to really directly receive that messaging. We talked about diabetes and creating messaging that touches on the different types and the different treatments. We went over puberty communications and various feedbacks from youth and clients. We went over the Living Well website, and we created a health literacy coloring book together. The Health Journal was a really amazing tool that Monica created that we were able to implement with our staff and youth that I still give away at every event I go to. And we did various distributions of messaging campaigns, both created before and during this project.
At LAYC specifically, we also took the initiative to develop different social media campaigns, basing them on different monthly health observances, such as teen dating violence awareness, for example, with a focus on bilingual content, knowing that our audience is mostly English and Spanish speakers, and also focusing on topics and, well, monthly health observances that are relevant for our youth. So again, the example of teen dating violence awareness is really important for that age group compared to, let's say, Alzheimer's awareness or colon cancer awareness, as these are later on in life and maybe not as relevant for them.
And just to add, because I get super excited when we're talking about the materials that we co-created. So, Brenton, I'm giving you a shout out because you came to us and you said, hey, I need something on diabetes. And I looked, and a lot of the stuff that we had was a little outdated, but we worked collaboratively together to create something that you can give to your community. In regards to puberty, I know that that we talked about the puberty communications. Your feedback and you sharing it with your communities was critical in creating something that we could then give out, not just to adults, but to the youth. And then the health journal. I mean, the health journal is something that we're so excited to see how you're using it and getting your feedback on how it can be improved in the future.
Hello again, everybody. So as you all have heard, we worked on several different collaborative campaigns together to solicit feedback from our CBOs and their respective community members as well. And as Monica mentioned, our CBOs did not hold back on the commentary, and that just made us as a public health agency be more mindful about the materials that we were creating and ensuring that they were accessible to the various communities that we were trying to reach. So a couple of examples of the feedback that we received was, obviously, the number one thing was using plain language. As a public health agency, a lot of the times we get caught with using very high register or very technical medical language, and it was very important for our CBOs to give us feedback, both our health and non-health CBOs, on terminology that's more accessible to their communities or easily understood. Especially as it related to the complicated health terminology and even the use of health literacy and how we were presenting that topic through our messaging campaigns. Another example was the use of culturally relevant concepts and language for your targeted audience. And this really included the importance of using culturally relevant imagery, messaging, and ways of providing information was also very important. And also being culturally sensitive and intentional on how we combat misinformation. The other example, and the other thing was incorporating an asset-based perspective for individuals, including using their cultural norms to encourage healthy behaviors and being mindful of that as well. Using non-stigmatizing language and being mindful, and a reminder to us to do no harm with the language that we were using in our campaigns. And just being mindful of that words and terminology can convey biases or further stigmatize the populations that we were trying to reach and potentially have an opposite effect on our intended call to action for those populations. So that was very important. And then also, different ways in which we could be more inclusive and representative of the populations that we were trying to reach, but also by showing them through our messaging campaigns, whether it was imagery, language, showing variety of demographics across, people with diverse abilities, being more intentional about the language that we're using to be more inclusive, especially when we had specific campaigns that were targeted to our LGBTQ plus community. And the puberty comms plan keeps coming up a lot, but it was very important for us to also be mindful of how our youth are showing up and representing and identifying and being responsible in the language that we're using to ensure that they're also feeling included as part of the materials that we created there. And lastly, providing meaningful translation and interpretation. It wasn't just enough to translate documents and do the word-for-word translations, but also the process of transcreation and ensuring the meaning did not get lost in translation and balancing our materials. Also exploring ways to provide access to information and resources through QR codes, also accounting for any technological difficulties that some of our populations might face and looking at different ways in which we can reach them as well.
And you can see up on the screen the diabetes piece. That's the one with the little guy that has the little round circles. So that's the piece that we co-created with the CBOs. And then also that's just a quick little preview of the coloring book that's going to be coming out. But again, none of that would be possible without collaborating with the CBOs. So some tips for creating a feedback loop. This is from our experience working as a DC Health Department with CBOs. So at first, it's essential to kind of conduct a mini communications audit. So through this communications audit, you kind of learn through discussions, who are you currently communicating with as a CBO? Who are you communicating with? Where are the gaps? where are there opportunities for growth? So if there's a certain demographic that you're not reaching, maybe we can work together to kind of create materials. For example, AU mentioned the LEP, Limited English Proficient Community. That's something that the DC Department of Health has expertise in. But likewise, there could be a group that the CBOs have expertise with, which include the youth. So that's kind of how we start off this relationship. How does your audience communicate? So one of the things that Melinda just brought up was the QR code. So I know that the CBOs were very direct in saying, okay, you need to put QR codes on everything. QR codes weren't necessarily a thing, but we started putting them on our materials because of your feedback. Then you identify who your key partners are. So obviously you are a key partner of ours because you are community building organizations in the community. But I remember there were some CBOs that were working with dental offices. There were some organizations that were working with daycares. So we need to figure out who our key partners are and who has the expertise that we need. So that was who are the trusted messengers, who is missing from your audience. So who is a subject matter expert that perhaps you don't have access to? We may have access to that, and vice versa, likewise. When it comes to co-creation, we obviously gathered feedback from the CBOs and we incorporated it into our messaging. But there were times where CBOs would create flyers or other communication materials and they would ask us for our feedback. In addition to all of this information gathering, we would test the messaging. So does it work? Does it work with the audiences that you're looking to reach? But one of my favorite things personally was when we went to do our site visits, I would love to see, or I love seeing our materials hanging up on your walls. I thought that was great. So impact and future collaboration.
The collaboration with community-based organizations has enhanced the effectiveness and relevance of our health literacy initiatives. And moving forward, we'll continue to engage with community-based organizations to further refine materials and reach more communities with essential health information. Together, we are going to make significant strides in advancing health literacy and promoting healthier communities. And we extend our gratitude to the community-based organizations for their invaluable partnership and feedback.
That's it, thank you.
Thank you for that great presentation on messaging materials. Now we're going to hear about how several of our partners integrated social needs assessment. So join us.
Good morning. Shannon Gopal with DC Health. Thank you. Introduce yourself.
Hi, good morning. My name is Simon Santo Domingo with CARECEN, Central American Resource Center.
This morning we'll be sharing CARECEN's implementation of a social needs assessment and referral tool. We'll discuss the importance of addressing social needs and the role of CBOs, CARECEN's implementation of LinkU, that was the social needs screening and referral tool, challenges and successes in social needs screening, and then lessons learned and advice for CBOs. So we connected initially over the COVID-19 pandemic in this collaborative. The pandemic really put a spotlight on how disease impacts different populations, different communities differently. We also saw that communities hit hardest by COVID were also the same ones that have been hit hardest by diabetes, hypertension, and other chronic conditions. To reduce health disparities, we must address the needs of the most vulnerable. And CBOs, because of their relationships within the community, are really the perfect partner to reach residents where they are. And so CBOs can identify and address needs that our residents struggle with. here, Caresen will talk a little bit more about LinkU and your experience with LinkU, but we used a tool, a comprehensive tool that was easy to navigate. CBOs can educate residents and connect them to resources by providing information and in an accessible way with clear action steps.
Good morning. Hope everybody is having a good morning today. I was a little bit late for breakfast, but Caresen's role in implementing our health literacy program surrounded a lot of different topics, and it touched on a lot of different things. But there is one specific tool that made our reach be much more than what we could have ever hoped for, and which is the use of technology, mainly LinkU. LinkU is a program or a piece of technology that DC Health developed that really expanded our ability to serve communities that we wouldn't be able to serve. For example, if a community member came to us seeking immigration services, we would have helped them. But if then they also tell, hey, do you guys offer some kind of financial assistance, or do you guys know where I can get some food? And we just happen to not know where we could refer them. LinkU was that for them. LinkU was a referral tool. And it was essentially something that we used to streamline the process of actually giving help to our community members. Talking a little bit about our outreach program, Caresen focused on engaging the community directly. We touched about 12,000 people in the last year that we started, or a little bit over a year now, since we started the program, with the great help of La Señora Maria, who is sitting here with us, and Alicia. Thank you so much for all the work you do out there. And also my colleague Jonathan, who is also part of our team member in guiding workshops that we do. When we get people in from the outreach that we do, we actually help them with a specific course that they arrive in, and in that course, that's when we teach them the tool of LinkU. With LinkU and the social needs assessment, we were able to assess over 130 people, and something that is quite fascinating about what we found is that over 90% of people listed financial need as their main need. Only about half of people listed, I don't say only, but half of people listed mental health as a primary need, and between 70% of people listed food, work as a primary need that was underserved. So at least 9 out of 10 people who go into LinkU will find something that they need critically. So this is why it's such an important thing to have an access to resource and have a resource to access in our community. But obviously, not everything is easy, right? We also found some challenges along the way. Mainly, the beginning, we didn't really understand it. So like anything, it takes a little bit of time to adapt. At first, we realized that the way that statistics got quantified in the referral tool were as a group. So it was sometimes hard to know what team member was doing what. And it wasn't not necessarily because we were trying to figure out what the workload was going to be, but it was simply to measure the impact that we were actually doing. And measure it as a group, we determined, okay, let's find our own metrics. Let's say individually we all need to have a certain amount of people that we should refer, that we should assess using the social needs assessment. And that social needs assessment was a fantastic tool because it basically gave us a personal insight into some people's lives. It gave us an idea of what people are going through. And post-pandemic, people are struggling financially, struggling with their mental health, struggling to find work even though unemployment rates are low, especially in our community. Caresen focused mainly with immigrants. So immigrants who are not yet documented don't have the capacity to find work legally. So they have to just get whatever they can. So having a referral tool is a fantastic way to be able to access those resources. Overall, the success of LinkU was that it allowed us to expand our reach. From the beginning, we referred about 63 people out of the 136 people that we assessed. So that is something that we actually wouldn't have been able to do if we didn't have LinkU. LinkU essentially allowed us to expand our arms and say, okay, we can help you in this particular case, but if we can't help you beyond it, here are places where you can go. And it empowered them, because it's not like they have to go to Google and find something specific or do some digging. It's a tool that's designed to just tell them, oh, this is what you need. These are the places where you can find that. It's simple. And yeah, 97% of people that took the test, took the assessment, listed at least one need that was underserved. If anybody wants to implement LinkU into their workflow, into their capacity to help people in the community, they should keep this in mind. First of all, training and sign-ups for the staff should occur the same day to ensure the team is all under the same umbrella. I had the problem where my team signed up and I signed up on a different day and I had to get technical support. And I don't know if that issue has been solved, but it's nobody's fault. It was just the way that it was implemented, that it wasn't correctly. And again, it's just a word of advice to do it all on the same day. If clients have a difficulty with technology, you can actually print copies of the social determinants of health assessment that LinkU will provide. So hand it to them in person, physically, if they feel a little bit hesitant to touch technology, and then put the data in after so that you can make that referral anyway. And then also integrate LinkU into your presentations. If you guys do workshops in your communities, if you guys do events, integrate it. It's not a separate thing. It's another arm that you have at your disposal. Okay. That is that. Do you guys have any questions about that? All right, thank you very much.
Thank you so much, Shannon and Karison. I really am impressed about how well you've used the tool. Now it's my pleasure to present with my colleague Monica on this Practice Change Learning Support Portal. So you've heard us talk about it quite a bit. I think we need to go to the next slide. Hold on. Here we are. That's where we were before. So remember I said there were three major parts of this program that we've started. And so it really is an online tool to advance health literacy. And it is a tool. It's still a work in progress. But it's really, as I've said before, I want to underscore yet again that the work that we're doing is for collaborative learning so that we can move towards practice change, right? We can't continue doing what we've always done, so we need to inform ourselves and learn about how and what we will do. We will look at why we wanted a portal, so I'll talk a little bit about that, and then I will hand it over to my colleague, Monica, who really was the person who developed and worked with Octo to develop the portal, etc. So we'll talk about portal content and goals and the design, and then we'll really underscore that where we are, etc. So I'm going to go to the next. So you've seen this slide before, right? But I really wanted to point out that the triangle in the middle is the portal. The portal is really intended to support the work, the conversations that we talked about, but also the personal health literacy, the organizational health literacy, and the professional health literacy. To date, we've mostly been working, as you've heard, with the non-health CBOs and with populations. So that's really where the part of the portal that is most developed to date. We still have a lot of work to do, but we are backing into it, as I talked about earlier. So here we are. What you see, this is kind of like the front page. When you open it up, you'll see that we have a place for residents, a place for community-based organizations, and a place for healthcare organizations. So we started with our end in mind, even though the whole thing is not built out. And so we're engaging and building as we go along. So why a portal? Really because it allows us the flexibility and the feedback. we know, for example, we've published that health literacy journal, and as soon as something goes wrong, something changes, we would have to rejig it. So what we've done is we've put it on the portal. You can actually go to the portal and get that health journal, and you can get the chapter that you want. If you've used up one piece when you went to the doctor's office, you can print another one, and then you can keep a whole stack for yourself. So that's one of the things. We really wanted to have a place where we could share with community-based organizations, and you've heard them talk about the materials that have been developed, and that's really where we're going to put it. We've put trainings on there already, and we're going to put what comes out of this conference on there. And really, ultimately, here is my dream. My dream is that we build a portal that ultimately is so powerful that health professionals will be writing prescriptions. Oh, go look at this on the Living Well DC website, right? So that is a little bit way out, but I think it's ultimately what we want to do. And I know some people are not comfortable with technology, and so that's why we print some things. But technology is of the future, and we're using QR codes because most people have a cell phone. So learning support can include how we think about smoking cessation. So now I'm going to pass it over to Monica, who's going to talk about the portal goals.
So one of the colleagues that was up here talked about LinkU as being an extension of the work that you already do. The portal is the same. So we want to be able to reach people in many different channels. So one of them is through paper, right? So through a health journal that you can give out to people. The portal itself was modeled after the health journal. So we wanted to be able to reach populations however they communicate best or what's easiest for them. So when we talk about the goals of the portal, one of them was access to resources. So just getting information about your health in plain language that's easy to understand. So that if you go to the doctor and they tell you you have diabetes, you can go to the site and you can learn about what diabetes is in an easy, comprehensible way. Community engagement. So the portal facilitates community engagement by providing opportunities for residents to participate in events and to participate in workshops and discussions. I think LCHC talked about the Living Well workshops that you were doing. So those workshops would be posted on the Living Well portal, and anyone who is interested, and as we continue to promote it, would go on there and would see these workshops or even your events, your community events, to learn where they can get maybe some free health screenings. Health education, as Dr. Arno just mentioned, the long-term vision of the portal, but professionals can refer their patients to the portal so that if what they're saying isn't necessarily falling or is understandable, they can refer people to the Living Well portal to advance their health literacy. Residents can access educational materials and tools to help advance health literacy within their families, and organizations and communities can foster stronger relationships. But then also for CBOs, you can get toolkits, you can watch videos for healthcare providers, you can learn about creating a stronger relationship with your patient and advancing health literacy throughout the community. So here we mentioned health education. On the site itself, there are just some general health terms that you can look up and some chronic health conditions, some general health conditions. And there are also resources that you can tap into to get more specific help. As far as the goals for the design of the page, as I mentioned earlier, it's a site that should be easy for you to use. It should be something that should have information that's useful to residents, to community building organizations, and to health providers to ultimately improve the health literacy of the district and advance health literacy. Improved engagement, again, includes class registrations or even downloading the health journal. So if one of your organizations doesn't have hard copies, you can refer people to the portal. And obviously videos. One of the campaigns that we had, as I mentioned before, the site was modeled after the health journal, was A Healthy You. So if, as I mentioned, you don't have copies of the health journal, or you only have them in English or in Spanish, you can go to the website and you can get them in the same in the 7 main languages found in the district. So this includes Korean, Chinese, Vietnamese, French, Amharic, Spanish. And one of the things that I really loved about the portal itself, you would think health literacy, it's such a vague term, it's not very sexy. But the truth is that people are very interested in improving their health. So when we first launched it, we actually created a video, and we broadcast this video, promoted it at local movie theaters. You would think people going to see a movie are just there to watch a movie, but there's a QR code. And so we were able to track when people used or visited the website. A lot of people visited the website after this came out. So let me play it for you.
It's time, DC. This is your wake-up call. It's time to start something. Start something good. Or even quit something, if that's your thing. Point is, it's time to get back on track. And DC Health is making it easy with Living Well DC, a resource with everything you need to get your health back on track. Whether you're dealing with a chronic condition or just want to live healthier and feel better, Living Well DC can help. See for yourself at livingwell.dc.gov.
30 seconds. Yeah. I don't know what I would do if I were in a movie theater and saw the video. I think I would click on the QR code. Do you want to take this slide, or do you?
We can do it.
Okay.
And so here's a little bit of the data. As we said, we've only kind of not just started, but we were starting to collect the data to see where the uptake has been. We were pleased to see that health knowledge was the biggest bucket, and then after that, people looking at diseases and conditions. But we have different tracking mechanisms that we're trying to use to understand and share that data. But really what we'd like to say is that the portal is still very much a work in progress. Our experience to date has really shown that it does have a lot of capacity. It really has been an excellent tool for our collaborative process to date. We have been able to apply some user testing, and obviously we've built it with sustainability in mind. So I do also invite your patience, but I also invite your feedback so that we can build it out together. So I think that's it. What I would like to say, thank you all. We are about to go to break.
Hello, everyone. I hope you enjoyed your short break. My name is Wander Mamtuktu. I'm with the DC Department of Health, and I'll be co-presenting with.
Hi, everyone. My name is Brinson Sanford, and I'm the Health Preparedness Coordinator for United Planning Organization.
Today, we'll be presenting a project data sampler, essentially a sample of all the data sets that we collected over the course of the grant. Again, it's just a sampler. It's not a holistic picture of all of the data that we collected. And the 3 major areas of focus for this presentation will be highlighting the monthly data sets reported by our community-based partners, and then highlighting a case study, which will be a workshop evaluation approach that we hope could be useful to other community-based partners. And finally, we'll highlight the DC Structural Vulnerability Index, which is a valuable tool that we found useful in identifying priority populations during the project period, particularly vulnerable populations at the start school neighborhood level. Again, for the workshop evaluation approach, United Planning Organization presented workshops on 3 specific areas. The first was chronic disease prevention, and the second was diabetes management and prevention and breast cancer awareness. And for the CBO monthly data reports, which we'll be highlighting, we disaggregated our data sets by race, by word, by limited English proficiency, and by foreign birth. And then finally, we'll highlight the Structural Vulnerability Index, the updates past COVID-19 pandemic. I'll turn it over to Brenton.
Hello, can you hear me? Hello, hello, hello. All right, we're up and we're at 'em. Okay, so again, my name is Brenton Sanford. I'm the Health Preparedness Coordinator for UPO. I'm also with United Planning Organization, and I'm just gonna go ahead and jump straight into it. So, since coming on to the grant up to now, we performed various workshops throughout the district. And so they were health literacy workshops, which was across the district. Number of workshops held. There were more than 3, but primarily the 3 were the 3 specific topics on chronic disease, diabetes, and another third topic as well. So the dates ran from October 2022 to March 2024. These workshops were held for DC residents in wards 5, 6, 7, and 8. What's important to know is how many people participated and who were these DC residents that participated. So we totaled about 105 residents that reported participating in these workshops. 42 were identified as male and 63 identified as female. 40% of the age group were 65 years of age or older, so in a numerical term, 42 individuals. 60% of the age group was younger than 65 years of age, so there were 63 individuals. So for the first workshop, which we held, which was on knowledge of chronic disease and prevention, we did a pre and post survey. So if you look at the graphs, the orange represents the post survey and the blue represents the pre-survey. So on the pre-survey, it was about 5 to 6 questions, and one of the questions that we pulled from the survey was, how comfortable are you with identifying preventative measures to prevent chronic diseases? Sorry, I had that slide. So while there was a diversity on the pre-survey, the following workshop, the data reports that 100% of the respondents selected very comfortable to identifying preventative measures to prevent chronic diseases on the post-survey. So if you look in the blue, for the pre-survey, most of the options were slightly comfortable and not at all. So each section was about 45.5%. So after that workshop, we were able to get 100% understanding on how to identify preventive measures to prevent chronic diseases. So for the second workshop, which was one of kind of my favorites, it was the knowledge on diabetes. So this one was kind of, personal to me because my family, they have issues with diabetes and pre-diabetic and things of that nature. So from that survey, we did a pre-survey and a post-survey. And the question that we pulled from the survey was, how comfortable are you if asked to answer the following question? What are a few side effects of not treating diabetes? So 76.5% respondents were slightly comfortable with the question. However, given the post-workshop, 88.2% were moderately comfortable. While that response is pretty good, they showed us some work that we had to continue to do throughout the district. And we were okay with that. That's why we partnered with DC Health Oakers team to generate the content to really help us make impactful, informed, and sound decisions. And so for the last one, which is kind of like one of my favorite because we did it at PD Green, which is where I'm stationed at, it's the breast cancer awareness workshop. And so the question that we pulled from that was, how comfortable are you with identifying or noticing the early signs of breast cancer? So again, remember the pre-survey was given in the blue and the post-survey was given in the orange. So the majority of the respondents were slightly comfortable with identifying early signs and symptoms of breast cancer prior to the workshop. So this is what they reported before any content was given, before any Q&A sessions, before the guest speakers came in and shared their lived and shared experience about this. Now, however, the post-survey administrator following the workshop showed that 100% of the participants selected very comfortable with identifying and or noticing the early signs of breast cancer. So this is one of my favorites because this one was very interesting. We had different dynamics, different groups, but everyone left this workshop informed and they were able to make sound decisions on breast cancer. And yes, we had men participate in this workshop as well. So I was very happy for that as well. And so now I'll turn it back over to my colleague, Wandy, who's going to present about the monthly data reports.
Yeah. And so we had, based on the work plan activities, the community-based partners we worked with over the period of the grant submitted monthly reports to DC Health. And the following charts will highlight event encounters across the district by each of our community-based partners over the grant period. As highlighted by Dr. Anno earlier on in the presentation, in year one, we had 6 community-based partners. And then in January of 2023, which coincided to so midway in year two, we had 2 additional partners join us. And so that was Hill DC from American University and La Clinica del Perbio. And so if you look at the chart, you can see that the number of attendees at events across the first year was steady in the early part of the second year, but gradually increased in year 3. And so that coincides with when the 2 additional CBOs joined the collaborative in January of 2023. And so that accounts for the increase that you notice across the bar chart. And you can also see that our predominant population at those events were African Americans, and the second highest number of attendees were Hispanics or Latinos, and that's consistent with our priority populations, because our priority population are minorities, predominantly residents of wards 4, 5, 7, and 8. And on the next slide, we disaggregated our data set by ward, and you can see that, again, in year 1, there was a high number of attendees, and then in year 2, a steady or slightly very ill-defined fashion of bar charts. Is difficult to describe, but yes, we had a shift in activities on our work plan. And so in the first year, the focus was COVID-related services, providing resources related to COVID testing, vaccination in the first year of the grant. And then from year 2 and year 3, we had more of our activities centered on advancing health literacy. And that kind of affected to a slight degree the number of the number of people that attended events across board in the district. However, we see that there was a slight increase in the number of people from Ward 4 because one of our partners, La Clinica, predominantly serves residents of Ward 4. That kind of explains what happened on this bar chart. Again, there are so many other factors that could account for some of the nuances we noticed in the previous chart, but yeah. This slide actually shows the data sets disaggregated by limited English proficiency and foreign birth. We see a steady increase in the number of residents who attended events that were limited English proficient, which was a priority population for our grant. The increase actually became marked from the beginning of the second year, which coincided with January 2023, when La Clinica del Perbio joined the collaborative. Their predominant population of focus is actually individuals who are limited English proficient. And now to the DC Structural Vulnerability Index. Dr. Anna's initial introductory slide highlighted the DC Structural Vulnerability Index that was initially adapted for COVID-19 pandemic. And so on our grant, we actually expanded on its applicability beyond COVID-19. And so we standardized what we initially had, which was a composite score of 10 variables, and increased it to 15 variables. Again, the DC Structural Vulnerability Index is a valuable tool in highlighting the most vulnerable populations by statistical neighborhood. So the granularity of the data set allows interventions to be focused on the communities that are most needing of our intervention across the district, and is a tool that can be utilized by CBOs and by other community members. Again, I highlighted that it consists of 15 equally weighted vulnerability criteria clustered into 6 domains that represent structural, economic, and medical vulnerability, with a composite score on a scale of 0 to 1. The higher the score, the greater the vulnerability. And that wraps up our presentation. Thank you.
And now I really am excited to welcome our Harvard partners who are our collaborative evaluation partners that we've worked with, as I said, even before the grant started, when we were putting it together. Welcome.
Good morning. My name is Elaine Meredith, and I'm a program coordinator with Howard University's Master of Public Health program. And today I get to speak with you all about collaborative evaluation, and specifically our collaborative work as the Advancing Health Literacy Evaluation team. So our team is led by Dr. Alicia Anderson, Dr. Pamela Carter-Nolan, and Dr. Carla Williams, and consists of Miss Brianna Jeffries, Miss Olivia Toomer, and myself. And I also want to extend a thank you to our administrative coordinator who is joining us today, who helped us with things like budget and acquiring our data analysis tools, Ms. Rahel Tibabu. In short, today we'll be focusing on evaluation, but more specifically, our collaborative work with DC Health. So when you're thinking about an evaluation, think about a systematic way for programs to assess their processes, outcomes, or value. The whole point of an evaluation is program improvement. So it shouldn't be thought of as like a final grade on a report card, but more so a reflection so that programs can improve their processes and outcomes. For our evaluation, we use the CDC's Program Evaluation Framework, which consists of a cycle of 6 steps and 4 standards that help to guide our work. Our evaluation approach was collaborative, process, and outcome. So as a collaborative evaluation, we worked with DC Health and our CBO partners. Our process evaluation involved learning how closely the program was implemented as planned. And then as a part of our outcome evaluation, we worked to determine how the program produced its intended results or reached its goals. In general, there are 4 main purposes of an evaluation, but you can see here that 3 of these, which are highlighted in the blue boxes, are aligned with our evaluation. And these included helping DC Health to improve the Advancing Health Literacy program processes, determine the effects of the health literacy intervention as it relates to organizational health literacy, and then also affect the program participants by being a catalyst for self-directed change. So our project consisted of 3 goals. The first, which was to be collaborative in our work during all the phases of the evaluation. Secondly, we aimed to conduct a process evaluation with a focus on the Health Literacy Learning Collaborative and the Health Literacy Portal. And our final goal was to conduct an outcome evaluation to learn the impact of the program among CBO staff. So here you can see our goals stratified by the approach that we used, and then underneath each goal are the indicators or measures that we use to assess them. So for example, for our goal 2, which is a process evaluation for the Health Literacy Learning Collaborative, we implemented an end of the session poll. So we used that to gather feedback from the CBO participants. And one of the pieces of feedback that we gathered from that was we need practical hands-on application of the health literacy for organizational spread. So then we took this feedback to DC Health, and you can see that happened in our bi-weekly meetings under goal 1. And DC Health responded in real time and said, okay, we're gonna put this training into our health literacy training curriculum. We also worked with DC Health to gather perspectives from CBOs at the end of 12 months of collaborative sessions. And the picture to the right is what the intro to that survey looked like for our CBO participants. We were also able to collaborate with CBOs, and through that we were able to fine-tune our tools through pilot testing activities. So for example, we took this brief feedback form pictured here to one of our collaborative sessions and asked the CBO participants, what do they think, what do we need to change? And here are some of our preliminary findings. So these are also organized by each one of our goals. So our key finding for goal 1 thus far has been that through having these bi-weekly meetings with DC Health, we were able to provide timely recommendations, and then DC Health was able to provide a real-time response. So based on those monthly collaborative session polls, there was a question that said, what did you find most beneficial from today's session? And two of the pieces of feedback that we received from that are listed here. And so one was getting to hear everyone's perspective on the opening question. And then also, I enjoyed the group discussions about what health equity looks like, which is in reference to one of those opening questions. So this feedback here is what led to DC Health using a prompt in the beginning of sessions to further engage the CBO participants. Our major finding for Goal 2 was based on the 12-month collaborative session poll. So looking back at the past 12 months, what did you think about the collaborative? And we found in that poll that 80% of the CBO participants noted that they were satisfied overall with the collaborative session. So in that 80%, you can see 30% noted the sessions as excellent and 50% noted it as very good. Also in that poll, we received the feedback that I found it very beneficial to hear how other organizations approach things. Then lastly, for our Goal 3, which is related to impact, we found through the health literacy assessment that about 74% of CBO staff members reported their organization was doing well as it relates to providing staff members with health literacy sensitivity training and awareness training. And about 19% recognized that their organization still needed improvement. We also evaluated the impact of the intervention through the community-based organization interviews. So during those interviews, we asked the question, what have you learned from the collaborative sessions? And one of our CBO members responded by saying this. This is in regards to the sessions. It helps me to think more broadly about what health literacy means. It's not only educational material, it can be a lot more. Here we have a chart of some of our preliminary recommendations in DC Health's response. And to conclude our talk today, evaluations are a powerful tool for organizations, especially when they're done in a collaborative manner. This adds value for the organizations themselves, the participants, as well as the evaluators. So if you're thinking about an evaluation for your organization, you can start by recognizing what key processes or outcomes that would be helpful for you guys to understand and start to engage your participants regarding their experiences. That is it. Thank you for your time.
Hi, good morning. So I am Leah Vargas. I'm from DC Department of Health.
And I'm Tania Ruiz from La Clínica del Pueblo.
And we are going to talk about how we take all of this information that we learned on this project and turn it into a model to apply at our organizations. So like Dr. Arno kicked off the talk today this morning about how we were really, the goal was to work with community-based organizations and partners in the community that are on the ground and develop together a organizational health literacy model that is tailored for non-health community-based organizations. So what you've been hearing so far are like pieces of the work we've been doing, right? We've talked about the collaborative, the trainings, the messaging, the language access and outreach, data, and the portal. So these were all pieces of a toolkit, and all of this is data, maybe not in the classic sense of numbers like Wendy and Brenton presented a few minutes ago, but information for us. So how do we take all of this and turn it into something that we can utilize and apply? And so that's what we're going to talk about. So I'm going to go over knowledge distillation and applied translational research for practice change. Tania's going to talk about what La Clínica implemented at their organization. And then we're going to kind of end this part of the session in the morning with what the organizational health literacy model looks like for non-health CBOs. And it's in development, but what it looks like so far. So really briefly, knowledge distillation is basically what I just talked about, right? Like how do we take all of this information and everything that we've learned and all the work we do, all this large amount of information and turn it into a model? So we are using a translational approach or principles from translational research, really about it's multidisciplinary, it's about collaboration, it's about incorporating community, and identifies and supports the adoption of best practices. So that was the approach that we used. This is a translational spectrum used in translational research. I just wanted to put it up there just to kind of show you that it's a process, right? It starts at this point of kind of basic science and benched science a lot of times, and how it can get transferred into something that is actually applied in communities. For the work that we did on this project, and our goal was to really change health literacy practice to impact population health. So in this framework, it applies to T4, which is the second green rectangle up there. And this component is really about collaboration, about learning from each other, and how to apply what research and science has taught us into a community applied setting. Now, La Clínica actually did this work. They may not have called it the same way, but they did this within their organization of how they can utilize their experience and apply it to their populations. And I'm going to turn it over to Tanya now to talk about that.
Good morning, everyone. I'm delighted to be here and talk about what we did at La Clínica in terms of health literacy. So just a really quick overview of La Clínica. We are actually a federally qualified health center and certified as a patient-centered medical home. We serve mainly the Latino immigrant community, and we provide direct services to 4,000 individuals per year. So now let's dive into the work that La Clínica has done in terms of health literacy. This is all the steps we took in our project in advancing health literacy. So we actually did like 7 big steps that I'm gonna go over through each one of them, but I just wanted to show like it was a process for all of us. And also the process continues and the work will continue. So the first one was we really needed to, we had to identify the need. And for a really long time, La Clínica has been developing culturally appropriate materials, culturally appropriate health education sessions, has been tailoring evidence-based curriculums for our population. But what this project really helped us on was actually to transition from a health education model to a health literacy model at La Clínica. Another big win from this project was that it was actually something that really pushed us to apply throughout the whole organization and not work on silos. So this allowed us to create something for the whole organization and not only for one area of La Clínica. The second step we took is that once we know that we already have like a good base, but we needed to develop this, we needed to create an integrated support system. And for this, we transitioned from a health communications committee to a health literacy committee. And we included people from different departments at La Clínica to gain perspectives from, clinical team, but also from the development team and also from operations and all the teams at La Clínica. So this allows us to create a more robust system that promoted a universal approach of health literacy in the organization. Sorry. Some of the topics we discussed during our health literacy committee meetings include, for example, public health campaigns, health education materials, science and at sites, and patient-client communications such as telephone system, spoken communication, audio, and electronic formats. Once we had the team, we also needed to do a lot of research and mainly like literature review. We evaluated our framework and we actually moved from an individual health literacy approach to a more organizational health literacy approach. We also did a lot of research around the 10 health literacy attributes, and these are 10 attributes that every organization needs to have in order to be considered a health literate organization. So we ended with the conclusion that health literacy is not an individual responsibility, rather it's something that organizations need to adapt to make changes to reduce the demand that is imposed in clients and community members so we can respond equitably to to the needs that our community has. After we did all the literature review, we also did an assessment. And the assessment was basically to gain some insights and understanding. It was basically like a scan of La Clinica on how we operate, how we do our health education sessions, how we provide services. So this assessment was implemented with our health literacy committee, but also with our community health workers cohort. And this was really important for us to, so we were able to have the community's insight around the health literacy and how we perform in health literacy overall. And also, this helped us a lot on how we can enhance our health literacy initiatives within the organization. And I forgot to mention, but the assessment was based on those 10 health literacy attributes I mentioned earlier. So I'm not going to go through all of that, but some things we found that we were doing well include, for example, that health literacy is actually a priority that supports the mission and vision of La Clinica. Staff members currently use like different resources to better explain to our clients topics around health, for example, food models, body parts, etc. La Clinica's consumer education materials are already concise. We use plain language and organized and formatted in an easy way for our community to understand. We use a lot of colors that we know that attract our community. We also do a lot of research. We research a lot on resources available for our community, so in case we need to refer someone, we know where to send them. And also staff members are good assessing like the patient's non-medical needs to address and provide appropriate support and referral to them. Some of the improvements we found is that leaders and managers continually, we need the continuous support, and to do that, of course, we need resources to maintain all the work we have been doing through this project. And also, we need to incorporate a little bit more into, like all staff members, maybe bringing this to like new staff coming, like receiving a health literacy training. So we are still, as I was mentioning, this is a work in progress, and we found these are some of the findings we had. And finally, we landed in a model of using health literacy precautions at La Clinica. So what we really want with this approach is to recognize that any patient at La Clinica may have low health literacy, and making all the information available for them, it's really important. So under the health literacy, universal health literacy approach, we have 3 main areas, which include spoken communication, written communication, and self-management supportive systems. As someone mentioned earlier, I think it was in the last session, health literacy is beyond health education. It's more complex than that. So by incorporating like spoken communication, written communication, and self-management and support systems in our model, we are able to catch all of that, everything that composes health literacy. So to finalize, we created a toolkit that includes like different resources for our staff, but also will be available for other organizations. Currently, it's in the last process of design, but we really want to publish this in our website and be a resource for other organizations that might benefit from having this list of resources, relevant information, interactive quizzes, how to create key messages, etc. So that's basically what we did at La Clinica.
Thank you, Tanya.
And good morning, everybody. I am delighted to introduce my colleague and friend, Dr. Leah Varga, who has really done a lot of work since she joined our team, and all of that distilling of the work, etc., and to put together, the practice change and the toolkit. I really insisted that I came here to introduce her. So thank you, Leah, for this and all the other work that you do. Go ahead.
Thank you, y'all. Don't make me get emotional up here. It's embarrassing, okay? Thank you, and I've been super lucky to be able to do this with such wonderful people. So thank you to a wonderful team in doing this work and just being open and flexible to so much of this. So, and I look forward to continuing it, right? Because the whole point of this is how do we make this sustainable? So like Clinica just presented of how they were able to implement and design a model and a toolkit for them as a federally qualified health center who serves the limited English proficient speaking population. We are doing, or our work is to do something similar for all of this collaborative work that has happened, right? So again, all of the presentations that happened this morning, all of our partnerships with the other community-based organizations, how do we take this and turn it into a model? It's a work in progress, but I'm gonna present today kind of where we're at today based on what we've learned so far. The grant ends on June 30th, so we're still gonna be analyzing data, we're still gonna be looking at things, but this is kind of where we're at right now. And again, using the translational approach and really how it can help us include best practices, how to adopt best practices, how to develop policy, and how do we do cost-benefit analysis when we're thinking about applying organizational health literacy within our agencies. So Tanya just talked about universal precautions. This is the AHRQ kind of guideline. This is really tailored, right? It's kind of circling back to what Dr. Arno presented. This is really tailored towards clinical settings. So organizations that provide clinical care. And it's great, but we are talking today about organizations that are not health organizations. So organizations that fill community needs and supports in other ways that were not traditionally centered on health, but how you can still implement health literacy into your programming. So the way we kind of approach this, right, we've been doing this for a couple of years, sitting in on collaborative meetings, trainings, going to outreach events, having messaging meetings, all of the stuff that's been presented so far. In addition to, we also did some interviews with our community-based partners. We interviewed their staff and their leadership on how they were able to implement health literacy into their programming and what that looked like. So through these interviews, we then kind of huddled at DC Health and did a lot of reading of all of the notes we took from our conversations with you and started developing themes from what we were learning from those interviews as well as our work together for the past couple of years. We developed a framework, which I'm going to show you in a second, and then again, turning it into a model. So this is kind of what the framework is looking like right now, based on the work that has been done and what we've learned from you again through the interview process. So in the center, we have organizational health literacy, and these pieces that are kind of coming through of what's important to know when you're implementing organizational health literacy at your agency. So understanding your organization, and I'm going to go through these a little bit more in a second. Understanding your organization, the social and structural determinants of health, relationships and strategic partnerships, being informed by and know your community, and engage with the community as trusted messengers, excuse me. And how these things all kind of work together. You see these arrows, right? And we're like kind of looking at the way these things relate. It's hard to say they're kind of almost all the same thing. They're pieces of the same thing, but they inform each other, they work together, and there might be some other things that still come up as we continue on this project and close out, but this is kind of where we're at now as far as what we've learned from all of you through this work. There's a lot here, so I'm not gonna go read this all. Eventually you all will get copies of this, but I wanted to kind of include some of the language that was used in this process, right? So the first one I'm gonna talk about of this model is if you want to be a health literate organization, you need to know your community, right? And I put here on the sides what the universal precautions that we're kind of centering through this, how this relates to some of the universal precautions that AHRQ provided for clinical settings. Well, this is what it can look like for non-clinical settings again. So know your community. Later, you're going to get an opportunity this afternoon to hear from individual CBOs and the way they implemented health literacy at their organizations. So I'm not going to try to steal any of that thunder, but please go to those afternoon sessions and you'll hear again a little bit more detailed about what that looks like. But some examples. American University, Heal DC, talked about how they went into their faith-based communities, and I know that they worked with the reverends and the pastors there because they had to understand, right, that you can't just walk into a faith-based setting saying, I'm here to talk about health literacy without really engaging the trusted messengers and the people. You have to know that the faith-based community needs their pastors involved, needs their leadership involved to really be kind of those go-betweens. So know who you're trying to reach and how you can kind of collaborate with other members to make sure that you are effective and that you're learning too, right? We don't know everything, like has been presented several times here. DC Health definitely does not know everything. So we need to all learn from each other and the experts in that space. La Clinica just presented about knowing who their constituents are, and then how, even as a federally qualified health center who's already doing the work, sitting back and saying, I still have more to learn, and I'm going to reach out and still make sure that I am being a health literate organization as a clinical setting and a clinical partner. The next thing is build capacity, internal and external relationships, collaborations, and partnerships. I think I'm going to pick on Finn right now from LAYC. One of the things they would tell us is how I think everyone at LAYC knew about health literacy, as well as Brenton from UPO, I think all of you, but just to, you all were integrating with all programs throughout, right? Your agencies, building internal relationships at the same time of getting to know each other more and collaborating more, knowing what your strengths and weaknesses are at your organizations, and then who might be able to complement that so you can work together. So these external partnerships and internal partnerships are super important. I know Far Southeast and Inner City and UPO, you all started joining up on things. So it's building those relationships, again, knowing who you are, knowing where you have more to learn, and then who might be able to kind of fill those gaps with you. Understanding your organization, I just kind of touched on this, knowing your strengths and gaps, leveraging your relationships, and adjusting your organizational health literacy toolkits as needed. So what we are presenting today as this toolkit and as this model, it's not a one-size-fits-all, as we know, right? So as you're doing the work and you know your own organization better than anyone else and better than an outsider, you can kind of adjust as needed to make sure that you're working within your group and your organization and your agency and applying some of the lessons learned that we can share here today. One thing I didn't mention about language, and this was back at Know Your Community, language is critical to this, and I can't believe I didn't say this, because it's not only access, right? Well, Melinda and Ed and Jackie talked about language access as far as the native tongue that you speak, but it's also about making it plain, and it's also about being inclusive. So it's all of these things about knowing your organization, knowing your community, making sure you're using inclusive language, you're speaking in the language people can understand, not that you can understand, right? And if you don't understand, make sure that you are leaving resources aside so that you can bring somebody on board that can provide that support to make sure that you're able to communicate with the community that you want to reach. Programming and service integration, really health literacy, we've talked about as a social determinant of health. Matching that with the other work that you're already doing. Garesen talked about immigration services. They do a lot of work with the immigrant community. How can they weave in health to those conversations, right? They weren't doing it before necessarily, but now they can with some of these tools. Simon talked about Link U. If somebody comes and says, hey, I was diagnosed with diabetes back in my home country and now I need help finding a support network here, those are ways that you can integrate with a tool like LinkU. You can integrate that into some of the service delivery that you've already done around other social determinants of health. Everybody, all of organizations really have a specialty area, a unique niche they fill, right, in the community. So just think about how that health can be weaved into that. and how it can be weaved into programming. I know a lot of it has to do with funding, but if you can weave health into other funding efforts and like complement each other, I think what the CBOs have what we've learned from you all on this project is you've done this like masterfully. And again, if you want to learn more about that, go to their sessions in the afternoon, because they'll share more about that, about how each one of them were able to connect health to some of the social determinants of health and structural determinants of health that they already address. And then engage as trusted messengers. I think Dr. Arno talked earlier in the morning about how DC Health did some great work around COVID, but not so great as well, I guess I shall say. Community-based organizations really fill this place as a bridge to the health systems for communities. A lot of communities may not trust healthcare systems, may not trust government organizations for very good reasons. Community-based organizations are that bridge point. You are the trusted messengers. You are the ones that the community trusts. So building up that capacity within your organizations is an important part of it. We also used some, we put up some resources here. We know also, like we're learning from COVID, having trusted information was really important, right? How to kind of combat like the bad information that was out there around COVID, all of the myths that were going on. You all, the community-based organizations, again, really fill that role in being able to be that source, that resource of trust for somebody who might have questions because they've been hearing crazy things online about whatever they're reading, right? So we wanted to make sure that we provide some resources on what trusted information looks like, where you can get it. Do No Harm is a guide about how to make sure that we're not stigmatizing communities in those conversations. So this is, I think, one of probably to me, the most critical elements of the work that you do is being those trusted messengers. So what's next? We're thinking about sustainability, and in a minute we'll have a sustainability panel. But I know for DC Health, we are going to continue building out this organizational health literacy model for non-health CBOs based on, again, wrapping up the work that we're doing together in this formal way. But we'll also be expanding it to clinical healthcare systems and clinical settings, as well as professionals. We are working with Healthy DC 2030, which is the strategic plan around health for DC, and making sure that health literacy is a component of that. And like we presented earlier, keep your eye open on that portal that's continuing to be developed. That will be the main resource for all of this information, for all of this kind of coming to something that hopefully you can all apply in your own settings, and you'll be able to find all of the resources there on that portal so that you can do that. And to be continued. We're now going to have a quick sustainability panel, talk a little bit more about sustainability. So I invite Reverend Judy to come on up from Inner City. Manuel, Shannon's going to take us through that. I'm gonna leave it there.
All right, thank you to our panel. Okay, all right, thanks. So just to piggyback from Leah's last presentation, we want to ensure that our residents are connected to the information and resources that they need to make healthful decisions so that we can improve individual health and then ultimately population health. We all play an important role in ensuring that this information is accessible, ensuring that the information is culturally tailored, that it's easily understandable, that it has clear action steps. I know, Dr. Arno, you mentioned earlier that CBOs, or have mentioned throughout the day, that CBOs really serve as the bridge between the community and health services. And so I'll start with the DC Health team. What mechanisms has DC Health put in place to ensure that CBOs have access to the resources to continuously train and update staff on best practices for health literacy?
I'm going to start. I think you've all heard or seen it presented all morning, right? Number one, engaging the community and getting direct feedback. So we heard about how important that was. We're building the portal. We didn't just build the portal and say, this is it, people, have at it. We are building it slowly, deliberately, so that it is kind of responsive. One of the key things, and I don't think we've actually, didn't voice it this morning, one of the key things was that we are building it on all of the tools that we're creating at the 5th grade reading level. This is not a process of dumbing down. It's a recognition that any one of us, regardless of how educated we think we are, will need some of this information at some points in our life. And when we are ill, no matter how well educated you are, you will just need something simple. So I think that is the kind of, I think leadership is important, and the practice change that we're doing here in the deliberative process is really, I think, part of how we plan to go forward.
Thank you.
I'll just add quickly another plug. Dr. Arno just mentioned the portal, but the portal will be the living space where this continues, and that things will continue to be shared. We want to make sure that we're not, of course, doing this in a vacuum. We want to make sure that we are sharing everything that we learn, and also will be a space to receive feedback. So once it's up and running, you'll be able to, again, kind of interact with the things on there and the toolkits, and then also let us know if there's something that you don't see that you need. So it's really going to continue on as a learning space. There's also the collaborative that was talked about early on by Edrin and Kimmy. We want to think about what that looks like. It was, I think, a really important space. You heard in the Howard evaluation also about sharing, sharing a space for CBOs to share what they're working on with other CBOs and learn from each other. And I think that space is really important to continue and sustain, and we hope to be able to do that. It might not look exactly the same, but in some version, that will be a way that we can make sure that the work is continuing, the conversations are continuing.
Thank you. The next question is for our partners. I would love to get your perspective. Inner City as a non-health organization, La Clinica as health care organization, what key strategies have you identified as essential for sustaining the health literacy model within your organizations?
Good. I know that I am the only thing, probably we're the last panel between lunch and, oh, we have Q&A, okay. All right, so I can, my team will tell you I tend to get a little winded, but I love absolutely the work that I get to do with the community. So bringing a love to the work, but as one of my colleagues said, consistency is the key. Being relentless in your engagement with the population that you're endeavoring to serve, and always being open to listening, right, to hearing what they say, because it is a methodology to speaking their language. My organization started out, we are in a parachurch ministry, our parent church. So the community development programs and services that we sought to reach were deliberate for families, youth, and children, vulnerable populations, was what our founding pastor wanted us to focus on, because she felt that that community was the church, right? And if we aren't doing that work in the community, we're not doing the work of the church. So they were all interrelated. So as I sought to expand and sit with her, we focused a lot of our grants on families and youth. And as we started to win them, the one that really, and I said this early on, sitting next to Brent I think we were at Latin American Youth Center, and I said, I absolutely love this grant, right? This is going to be one of the most, and it was very early on, because we were given the challenge to be innovative, to come up with new ideas. And just because it hadn't been done before didn't mean you couldn't do it. You just had to run it by Dr. Arnaud and explain it in a way that made sense to the goals of the health literacy grant. So I certainly appreciated the opportunity to be able to engage the youth that we served in Child and Family Services Agency and the Department of Youth Rehabilitation Services and their families. So we integrated our work around health literacy, focusing deliberately to them. But I recognized that my primary population of young people could not look like me because they saw me as the auntie, the grandmother. So I immediately engaged people that looked like them, and you'll be able to meet them later on today as they do the presentation on how we evolved our concept to reach the youth and to also incorporate a very right now message around violence and public health. Oh, and I'm sorry, if you don't know, I'm Reverend Judy Shepherd Gore, and I'm the Executive Director of Inner City Collaborative, CDC. Sorry.
Thank you, Reverend. I think it's before noon, so buenos dias still. Everybody, I'm Manuel Díaz Ramírez. I'm the Director of Community Health Action at La Clínica del Pueblo. So some of the key strategies that we have identified to continue implementing this model within La Clínica del Pueblo, serving Latino communities, is from the beginning, we have to be intentional on applying to a new model like this. Any new initiative, any new model, any new concept or knowledge or technology that La Clínica applies for, funding for, since the beginning, we always apply it considering that we are going to end up, once those funds end, implementing all those core elements within our organization, how we can incorporate those core elements, because that's the best way to serve our communities, not initiatives that end when funds end, right? Also, another strategy that we will continue implementing is having us as leaders in the organizations continue commitment to support health literacy efforts through our funding, prospecting initiatives, work, through our budgeting process, how we allocate the necessary resources within our internal budgets to continue implementing the model. Also, another strategy is we have to continue training our staff. This is a knowledge model that you cannot train only once. We have to continue remembering because this is an ongoing process. So for that, staff training, providing capacity building efforts to our staff members, including our community health workers or peer health promoters, promotores de salud, is crucial to continue implementing this model. Promotores de salud, community health workers, are a key element of the implementation of any health literacy model that we want to implement. Integration is another strategy that we will continue to implement beyond this initiative. As my colleague Tania mentioned before, our health literacy committee is a work group within La Clínica that has a representation from each department, each unit, that produces messages at different levels for our patients and community members. So integration has to be intentional, and we have to continue working every day on ensuring this integration within teams that doesn't come naturally, right? Because clinical teams are focused on their own duties, while educational teams or community health work teams are doing also theirs. We have to foster that integration, that dialogue between these teams to ensure we are continue implementing the model. And also, I would say, a strong partnership and continue having a continued strong partnership with DC Health. It's crucial for implementing this model, from funding, from the right allocation of resources, to technical assistance, to ensure that also we get higher scores in initiatives across DC Health funding opportunities, but also under the DC government, other initiatives for organizations that are actually implementing a health literacy model. If we get a higher score in our application process, we will ensuring that organizations use these elements in their applications.
Thank you so much. And yep.
Something that Manuel said really made me tick, and I should have said it earlier. Integration has to be intentional. So I do think that the model, and I did kind of try to be brief by saying earlier that all that you've seen today is part of the plan. I think we have to find a way. We did it to DC Health, so it was not just OHE. We clearly collaborated with the Office of Communications as well as the Community Health CHA as well. But our next steps includes, and we're going to back into it, and Dr. Bennett confirmed that this morning. This is just a kind of pause as we think about what we've learned. DC Health is going to take on the task of becoming ourselves a health literate organization. And that means that we are going to leverage all the learning that we have done with you to be able to respond appropriately. Leah mentioned in her presentation that there's something called Healthy DC 2030. There's also something called the Healthy DC 2030 Steering Committee. One of the top things that they have selected to become a priority through 2030 is to make us a health literate city. And that means the health literacy, all of those 3 buckets that we talked about. That also includes our hospital associations, and they have promised to partner with us. So we can lead the way, but we can't do it alone. But I think this model that we have developed together and our commitment to continue the collaborative and to continue the feedback, because we don't know everything still. We're still going to create publications that it's going to hit the streets, like the puberty one. And it's like, nah, we're going to have to do something a little bit different. So I think we have to figure out a way to keep this going. So sorry if I took up too much of your time.
No, absolutely. Do we have time for one last question or no? Okay, yeah, one last question for our partners as well. Everyone on the panel has identified the importance of partnerships in continuing to move this forward. I'm sorry, can you describe any partnerships or collaborations with other community organizations, healthcare providers, or stakeholders that have been crucial to the success of this program and your plans to maintain or enhance these partnerships?
Well, recently we were awarded, we had the opportunity to work with Cities for Peace and the International Association for Human Values in applying for a grant through the Department of Behavioral Health. We did find in a lot of the surveys and the Google Docs that Camry was creating, and when we were doing our tabling at Giant and Aldi's and community health fairs with UPO and Far Southeast, when we had those surveys returned to us, there were a lot of responses related to mental health, food insecurity, just not really knowing where to turn when they had health questions. So not knowing how to navigate what resources were out there for them. So in this partnership with Cities for Peace and International Association, we have created what we call a Ambassadors for Peace certification program, where we are actually working with young people because, as Ed said, you know, that is probably our biggest challenge, even though I work mentoring young people for the past 8 years that are justice involved, keeping them involved and keeping them on a positive note, working with their families to ensure that they're keeping their mental health appointments, that they're going to and from, you know, even just healthcare appointments, making sure that they're not depending on that foster parent or the group home to ask all the questions when they get to the doctor's office. So we were able to create a program called Too Good for Drugs and Violence, where we were able to teach them how to do other things to cope rather than use marijuana or other stimulants like alcohol to cope. They are now taking and learning how to meditate and to take breathing exercises. They're now able to focus more on themselves spiritually and to also develop more realistic questions and responses to their behavior. I used to get this comment, and I would ask the young people, what are they talking about? They would say, "You throwing me off." And I would say, what am I throwing you off of? But it was such a common expression. I had, I'm one of those people like, no, I really need to know what that means. So, and it was their way of not really addressing what was really bothering them, what was really the thing that was getting on their nerves or throwing them off. So, and most of the time it had to relate with some trauma or some mental or emotional issue that was not resolved. So, partnering with, and when Wandy and Leah came out, one of the things that they did say, well, how are you going to sustain the momentum of what you created? We deliberately designed platforms where young people were, right, where their families were. So, they always have that PDA or that phone in their hand. So we had to have a social media construct that really resonated with them. And it couldn't look like me, so it had to look like them. So we deliberately set out to do that. The certification for Peace Ambassadors is a great program because it gives us an opportunity to talk about the violence and the public health threat that it has, why drugs are being used as an escape and an alternative to really dealing with issues that they can really face if we give them the tools to do so. And teaching them how to eat healthy. So a major component that they leave, like we teach them, how to prepare a meal, a healthy meal, as opposed to the carry out. And we did a whole seminar, and I'll wrap up on this, on carry out, that Chinese restaurant at the store, the corner store, as opposed to you preparing a meal, what is in the McDonald's, not to knock any of those establishments, but to really give a contrast to a healthy eating lifestyle, both spiritually, emotionally, and physically. And DBH was a way of us doing that. And our Advancing Health Literacy grant we were able to leverage that in order to obtain that one.
Thank you, Reverend. One of La Clínica's core principles is partnerships. So La Clínica believes that we cannot do the work that we are supposed to be doing in the community by ourselves. We need our partners. So one of the great ways this initiative was designed is allow La Clínica to enhance the implementation of this initiative through our existing network of strategic community partnerships. In more than 40 years, La Clínica has developed a strong relationship with different community organizations. Many of those are in this gathering this morning. Latin American Youth Center, Centronia, Carecen, right, are sister organizations, partner organizations that support and contribute to, their role contribute to the same goal that we all have for serving our communities. So being intentional in building and maintaining those relationships is crucial for us. But also our crucial partner in these efforts were our community members, our community health workers, our promotores de salud. They were crucial to provide us input. They were crucial to give us feedback and guidance on how they understood these elements and what they see as a priority to develop a more health literate organization, La Clínica del Pueblo. So partnering with community members is crucial for any initiative like this.
Absolutely, and I just want to add, we partnered with the Family Strengthening Collaboratives Far Southeast, East of the River United Planning Organization, because they are certainly working in the same communities as we are. So it was a natural for us to seek them out in doing some of the things that they were already doing and doing well, so that we could not only table and share information and share resources, but oftentimes we were serving the same clientele.
Just very quickly, as we say that we have to be intentional in other elements on implementing this initiative, building partnership has to be also intentional. So I like to use a metaphor that my team knows that I use some frequency. It's this initiative support from a health equity perspective to build safe spaces. When we work on being intentional or building and maintaining and enhancing these strategic community partnerships, we are contributing to build DC, in specific, a safe space for all of our communities. And a safe space, as I use as a metaphor, is not only built on walls and doors. Safe space, we all made safe spaces. Our role in the communities, whatever is the organization that we're working for, we are making DC a safe space for all of our communities.
Yep. Love that, thank you. Yep. Thank you.
Thank you, everyone. We've got a
Thank you to our panel.
Thank you, Reverend Judy. Thank you, Manuel. Thank you for your wonderful work and for contributing to this conversation. Do you have a time?
Oh, 12:12.
It's 12:12. Oh my gosh. All right. Thank you, everyone. We have some Q&A built in, but we got so excited with the presentation that we went over time. So we're still going to do a really brief Q&A just to open up the floor for some questions. But also, just because if we don't get to your question today because of time, there are other opportunities. We have QR codes scattered around the conference center. That is a QR code for you to send in a question to us so that we can respond. Also, we are all going to be around, so if there's someone that you see that you wanted to ask a question to, just please, if you see a yellow lanyard, that is somebody who is part of the DC Health team. They can answer questions for you if you want to kind of approach us out in the conference center as well. We'll take a couple of kind of high-level questions before we break for lunch. I know everybody's probably hungry, so. And Chris Charles, who is a wonderful DC Health team member, will be guiding the question and answer session.
Good afternoon, everyone. All right, so first, I did see some of the questions that you guys were putting in, and the first thing I want to address is, yes, we will be adding the portals, the slides, the presentations onto the portal, the Living Well DC portal. And feel free to add any other questions you have into the QR code that you see. So are there any questions from the audience? And we will come out to you if you want to raise your hands. Oh, you guys are a shy bunch. Shy bunch, huh? All right. So we'll go with okay. All right. So one of the first questions that I have here is, how can individual healthcare providers or healthcare organizations become a part of Health Literacy Collaborative? Dr. Arnold, would you?
Well, one of the things we said, we were building it slowly, and you did see, if you're the healthcare organization who's asking the question, that there were circles that said healthcare organizations. We are backing into it. So notice that we have La Clinica was in our kind of second year. And I think I also, if you may have missed it, but I also put an asterisk on a slide that said we're doing some early translation with DCPCA. DCPCA, and that means DC Primary Care Association, is really a kind of a working group or I don't know what they call it, membership group, that's the word, membership group of all the federally qualified centers in the city, right? So that is going to be our first kind of back into that. And we're going to invite them to participate. I also mentioned that we are going to be working with, when we get the health literacy, and it's something just occurred to me, can we become a health literate city by 2030, which is what our plan is. Once we start working with those healthcare organizations, we are going to kind of share this model that we've had with them about how to do the work. So we don't want to rush into it, but we're definitely going to have our FQHC partners as our first bucket of health serving organizations in the collaborative, and then go from there. And so that's the kind of high level plan. But we're, you know, there's no, what we want to build is a no wrong door and anybody can participate, but we wanted to keep this as a safe space for the non-health CBOs to really bloom in this work. And I think you guys have seen how they have bloomed and how we want them to continue to bloom.
So for the next question, did any of the organizations tackle HIPAA in their health literacy conversations? As a healthcare organization, something we struggle with is people and families want health communication to be convenient, but that often compromises PHI. So is it important that people understand why we need to take precautions? I wonder how this can be shared with non-health CBOs to allow to understand how to communicate with their providers and about health in a way that takes HIPAA into consideration.
That's a great question. I'll do my best. And if there's any community-based organization here that tackled this at your place, just please feel free to come on up and jump in. But we didn't, I think an important element, right, was community-based organizations fill a role in the community that is not necessarily one that's collecting protected health information. They're connecting people to are the ones that collect that protected health information. So to my knowledge, and correct me if I'm wrong, there were no HIPAA issues for this project because these are not clinical organizations that are collecting this. Suyana from La Clínica del Pueblo, however, has her hand up, so she might want to add oh, okay, yes, okay. And that's an important distinction to make, is that the community-based organizations that are non-health organizations are bridges. They're not providing clinical practice or services. They are bridging to that service and that healthcare system. So, and then that's where, you know, HIPAA and the PHI would kind of come into play there. But I think that's an important element, though, to keep in mind as we continue to expand this work. But we didn't have those issues on this project because of the way we were approaching health in the non-health CBOs.
Thank you. And because we're running a little bit over, we're going to move now, transition into lunch, and we'll be answering more questions during lunchtime. Thank you.